Well, thanks very much, and I really want to thank Drs. Cookson and Gerard for continuing to include me in the faculty. It's been a lot of fun to keep doing this course over time and watch it evolve with new data and new trials in our disease space. As mentioned, I'm going to be covering the earliest part of what we could call advanced prostate cancer, which is that of biochemical recurrence. We'll talk a little bit about how we define, how we risk stratify, and then what are options for both local and systemic management for men with biochemical recurrence. My financial disclosures are all in non-muscle invasive bladder cancer, so they're not going to be relevant. But really what I'm going to be primarily basing this talk on are the 2024 AUA SUO Astro Salvage Prostate Cancer Guidelines, which were released and highlighted at last year's annual meeting. The way I'd like to organize the next few minutes is to first discuss the entity of biochemical recurrence, understanding how do we define it letter of the law by the guidelines, how should we be thinking about risk stratification in clinical practice, and then we'll cover local therapy with salvage radiation and really get into some of the weeds about how we do salvage radiotherapy, including the use of concurrent ADT, and finish with a little bit of old and new data on salvage systemic therapy for biochemical recurrence. So I think it's very important to start just by understanding what is the AUA guideline definition, and especially for trainees and for examinations here, understanding that the AUA defines biochemical recurrence as a PSA greater than or equal to 0.2 with a second confirmatory value greater than or equal to 0.2. Very important, it takes two PSAs to define biochemical recurrence. But I think while it's important to know the letter of the law, it's also important to understand in clinical practice that not all men with a detectable PSA after surgery are at the same risk to subsequently develop metastatic disease. And with that concept in mind, this is a study from Cleveland Clinic that looked at 14 different definitions of biochemical recurrence and correlated them with patients' risk of subsequent disease progression. And they generated all sorts of fun curves like this. But what's really important to know about this study is that what they showed was that the optimal definition of biochemical recurrence actually depended on the patient's disease risk. So if the patient had a nomogram 5-year progression-free survival of less than 50%, indicating clinically high-risk disease, then the best definition of biochemical recurrence was a single PSA greater than or equal to 0.05. On the flip side, if a patient had a nomogram predicted 5-year progression-free survival more than 90%, indicating clinically low-risk disease, then the best definition of biochemical recurrence was a PSA greater than or equal to 0.4 and rising. So really the first important take-home point that I want to leave you with here is that we may use a lower threshold of PSA to define and, as we'll talk about, importantly, to treat biochemical recurrence in patients who have clinically higher risk disease. I'll spend one slide on biochemical recurrence after radiation therapy. What should you know about it? First, how is it defined? It's currently defined by what we call the Phoenix criteria, which is the nadir PSA a patient achieves after radiation plus 2. What do the guidelines tell us about how we evaluate it? The guidelines tell us that in patients for whom you would be considering salvage local therapies who have biochemical recurrence after radiation, we should do a prostate biopsy. And basically what this guideline statement is a nod to is to say that even in 2025, a patient with biochemical recurrence after radiation who has a positive PSMA that lights up in the prostate is not defined as biochemical recurrence. We still have to do the prostate biopsy. Now, what if we do the biopsy and it's positive in a patient who would be a candidate for salvage local therapy? Then shared decision-making, we should offer salvage radical prostatectomy, cryoablation, HIFU, or re-irradiation. Now, what about after focal therapy? Again, the guidelines do have some statement on this, which is evaluation and management of suspected non-metastatic recurrence. And what they tell us is that when we are considering salvage local therapy following focal ablation, we should offer whole gland treatment at that point with either surgery or salvage radiotherapy. Now, back to biochemical recurrence after radical prostatectomy. Studies have indicated that upwards of 1/3 of patients who undergo surgery will experience biochemical recurrence, and it'll be interesting to see as time evolves and we shift to operating on unfavorable and high-risk disease whether this number even goes up. But what's really important to understand about the natural history of biochemical recurrence is that it is heterogeneous and that it might be quite prolonged. So what do I mean by heterogeneous? What I mean is that biochemical recurrence nearly always comes before systemic progression or death from prostate cancer, but biochemical recurrence by no means universally translates into systemic progression or death from prostate cancer. As we mentioned, many, many more men will have a detectable PSA after surgery than will ever develop a bone metastatic disease, and therefore we have to be critically considering the competing risks, patient's age, other health issues. And in fact, one study demonstrated that over the 15 years after diagnosis of biochemical recurrence, patients were as likely to die from competing risks as they were from prostate cancer. Makes treatment selection very, very important. Now, I also mentioned that the time course of biochemical recurrence may be quite prolonged. This is sort of one of those named studies in urology that gets quoted. It's over 25 years old, but I do think that it's important to know some of these benchmark data that have helped to define the natural history. It's called the POUND study. It's not a clinical trial. It's an observational cohort study from Hopkins that followed 304 patients with biochemical recurrence for just over 5 years. And during that time, they found that about a third of these patients were diagnosed with metastatic disease. The median time in this study from biochemical recurrence to the diagnosis of metastatic disease was 8 years, from metastatic disease to death from prostate cancer 5 years, which gave a window of 13 years from biochemical recurrence to death from prostate cancer, quite prolonged. And remember, this is in an era before we had any of the life-prolonging therapies that the rest of today is going to be spent on, so this window just continues to expand, again emphasizing the importance of considering competing risks of mortality when we're thinking about the management of biochemical recurrence. Now, I mentioned that there are ways to risk stratify the definition. We also have to think about how do we risk stratify patients with biochemical recurrence, and there are several different published risk models. This is a nomogram that was developed from a multi-center experience of over 2,200 men with biochemical recurrence who were followed for just about 4 years. And you can see the elements that go into this nomogram here: age, which is sort of an indication of competing risks, some of the PSA parameters like time to biochemical recurrence and doubling time, and then pathology from surgery, Gleason score, tumor stage, margin status, lymph node status. And you can see that this nomogram allows the calculation for patient counseling of the risk of death from prostate cancer in 5, 10, and 15 years after biochemical recurrence, which you could argue is ultimately what that patient is really interested in when you're talking to them in clinic and counseling about biochemical recurrence. Now, recognizing that maybe everybody in clinic doesn't want to calculate a nomogram, which does require a bit, the EAU has come out with a much simplified risk model, which is just risk groups based on 2 criteria. And for surgical patients, it's Gleason score at surgery and PSA doubling time. And they define low risk and high risk biochemical recurrence. And the EAU has actually validated this in over 1,000 men with long-term follow-up after surgery. And you can see very nicely the separation of cancer-specific survival between patients classified as low and high-risk biochemical recurrence by the EAU risk groups. Now, the AUA ASTRO-SUO guidelines doesn't specifically endorse one risk model. What we say is that you should use prognostic factors, and those prognostic factors are the ones that we've just been talking about. There's a table in the guidelines that lists them to counsel patients about their risk of clinical progression after they've been diagnosed with biochemical recurrence. Now let's move to how do we evaluate the patient in terms of imaging. And again, to put us on the same page, conventional imaging are things like bone scans, CT, MRI, molecular, next-generation imaging. Really, in 2025, this means PSMA PET. So what's the data to support using PSMA PET to stage patients with biochemical recurrence? There have actually been several prospective clinical trials to help define the role of PSMA PET. This is the CONDOR Phase 3 trial. 208 patients with biochemical recurrence who had negative or equivocal conventional imaging then had PSMA PET. The results of the PET scan were compared to a reference composite standard of pathology, imaging, and PSA follow-up. Correct localization rate in CONDOR was about 85% across 3 readers. Very interestingly, almost 2/3 of patients in the study had a change in their management plan of biochemical recurrence based on the results of a PSMA PET. So patients may have been planned for some sort of salvage local therapy. PSMA PET had findings outside the pelvis, and management was changed. And we're going to come back to this later in the talk, but also very importantly from CONDOR, what this study showed was that the ability of the PSMA PET to detect recurrent disease in the biochemical recurrence setting was directly correlated with the PSA value at the time that the PET scan was obtained, and that's somewhat intuitive. So what you can see on the far right of the graph is for patients with biochemical recurrence who have a PSA of 5 or more at the time the PET scan is obtained, 95+% of those patients will have a positive scan. But even on the flip side, for patients who have a PSMA PET done at the time that we would call early biochemical recurrence, a PSA less than 0.5, 35 to 40% of those patients will still have a positive scan, indicating the value of obtaining staging imaging even in men with what we would call early biochemical recurrence. So what do our guidelines tell us about imaging? In a patient with biochemical recurrence, we may obtain a PSMA PET, but very specifically, in a patient with biochemical recurrence for whom we are considering salvage local therapy like radiation, we should get a PSMA PET. Why? Because we want to exclude those patients who have extrapelvic or distant metastatic disease from salvage local therapy. Very important second take-home point I want to leave you with from my talk here is be careful about the results of a negative PSMA PET in a patient with biochemical recurrence. So the guidelines tell us that if we're going to do salvage radiation, we should get the PET first. But very importantly, the guidelines also tell us that if we get the PET and it's negative, we should still go ahead and do the salvage radiation therapy. Don't withhold the radiation if the PET scan's negative. Why? Because the detection is not yet high enough at low levels of PSA to identify micrometastatic disease that may be in the prostatic fossa and may be effectively treated with salvage radiotherapy. Is there any role for conventional imaging in addition to PSMA PET in the modern era? And the guidelines tell us that yes, we may still obtain a pelvic MRI also. Why? Because there are data from our center and others that have showed potential enhanced detection of prostatic bed recurrence with MRI that may then guide the salvage therapy paradigm. Now, when we start to think about treatment of biochemical recurrence, a fundamental question to ask is whether or not salvage therapy can interrupt what I've just shown you about the natural history of biochemical recurrence. And unfortunately, we don't have at this time prospective randomized trials of patients with biochemical recurrence who have been randomly assigned surgery or observation to tell us. So what we do have are a series of observational studies that have collectively indicated that treatment of biochemical recurrence can interrupt this natural history. This was a follow-up study from the Hopkins cohort, now 635 men with biochemical recurrence, of whom 238 got salvage radiation, and with a median follow-up of 9 years, again, albeit in retrospective data, what they showed was that among men with biochemical recurrence, those who got salvage radiation therapy, significantly better cancer-specific, significantly better overall survival. A similar study designed in a larger series of over 1,800 men with biochemical recurrence, of whom just about a third got salvage radiation therapy with long-term follow-up, used propensity score matching to help to try to adjust for some of the confounders that are inherent to a retrospective study design. And what they showed was that, again, among men with biochemical recurrence, those who got salvage radiation, significantly better metastasis-free, significantly better overall survival, and these results were maintained on multivariable analysis. Which really brings us to the salvage therapy guideline statement 1, which is that we should inform our patients with biochemical recurrence that salvage radiation therapy is most effective when given at lower levels of PSA. That's the concept of what we call early salvage radiotherapy. The data to support early salvage radiotherapy has come from a number of centers. This is one from our Mayo Clinic Radiation Oncology Group, 1,100 men treated with salvage radiation, 9 years of follow-up. And what they identified was the key prognostic factor with salvage radiotherapy was the pre-salvage radiotherapy PSA. So what you can see here is that patients who got salvage radiation therapy with a PSA less than or equal to 0.5, significantly lower risks of secondary biochemical recurrence, significantly lower risks of developing distant metastatic disease, significantly lower risks of death from prostate cancer. This is a multi-center experience of almost 2,500 men treated with salvage radiation, follow-up for 5 years. And what they showed was that if you got salvage radiation with a PSA less than 0.2, your subsequent 5-year biochemical recurrence-free survival exceeded 70%. If it was 0.2 to 0.5, it's over 60%. But as the pre-salvage radiotherapy PSA goes up, your subsequent 5-year biochemical recurrence-free survival decreases, emphasizing the value of early salvage radiotherapy. So what do our guidelines tell us? We should provide salvage radiation therapy with a PSA less than 0.5, and in higher risk patients, we may even offer it with a PSA value less than 0.2. Now, one of the questions that comes up when we're using salvage radiation therapy is, in addition to the prostate fossa, should we also radiate the pelvic lymph nodes? What do the guidelines tell us? The guidelines tell us that we may expand the radiation fields to also include the pelvic lymph nodes, but if we do so, we should counsel patients on the increased adverse side effect profile associated with expanding the radiation fields. How about using ADT with salvage radiation? Another common question. Should patients getting salvage radiation have concurrent ADT? We actually have several prospective randomized trials to help inform practice. This is a French trial that took men getting salvage radiation and randomized them to 6 months of ADT or not. The primary endpoint was progression-free survival. Over 700 patients, over 5 years of follow-up, and what they showed was adding 6 months of ADT to salvage radiation significantly improved progression-free survival with the hazard ratio you can see here of 0.5. They then did a long-term assessment of their study and confirmed the results of the primary analysis, benefit of 6 months of ADT with salvage radiotherapy. A second prospective study in this disease space that's gotten a lot of attention was in the New England Journal of Medicine, led by Bill Shipley, randomized men getting salvage radiation to 2 years of high-dose oral bicalutamide or not, again over 700 patients, now with 13 years of follow-up and a primary endpoint of overall survival. And what they showed was adding 2 years of high-dose oral bicalutamide to salvage radiation, significantly better overall survival, significantly lower risk of death from prostate cancer. So what do the guidelines tell us? We should offer ADT with salvage radiation to patients getting salvage radiation who have any of those high-risk features, including lymph node positive disease. We should discuss with patients the side effects of ADT and the impact of ADT on their existing comorbidities. For patients getting salvage radiation without high-risk features, they may get salvage radiotherapy alone. And in terms of details of treatment delivery, if you're going to use ADT with salvage radiation, minimum of 4 to 6 months, and in patients with the highest risk features, may extend that even up to 2 years. I'll finish with just a few words about what's the role of systemic therapy, salvage systemic therapy for patients with biochemical recurrence. This is not a new concept. This has been looked at in a variety of different observational series here. One on the left of over 2,000 men with biochemical recurrence after either surgery or radiation. No difference in all-cause or prostate cancer mortality with early ADT for a rising PSA. Study on the right, nearly 6,000 men with biochemical recurrence showed that in patients with the PSA doubling time less than 9 months, so a very high-risk cohort, using early ADT did delay both prostate cancer-specific and all-cause mortality. But again, retrospective studies, heterogeneous cohorts. There's only one prospective clinical trial here. I'll mention it if for no other reason than the name. It's called the TOAD trial. It was out of Australia and New Zealand. Nearly 300 men with biochemical recurrence, primarily after radiation therapy. They were randomized to immediate ADT or ADT at least 2 years later. The trial was closed early to accrual, so there are some statistical considerations, but despite that, they did show a significant improvement in 5-year overall survival in the cohort that got immediate ADT. So we've got one prospective trial, we've got a variety of different retrospective studies. Where do the guidelines come down on this? The guidelines tell us that we shouldn't routinely use ADT for patients with non-metastatic biochemical recurrence in a rising PSA. If we do it, we should consider intermittent ADT, but really we should be thinking about observation or clinical trial enrollment in these patients. And of course, right after guidelines come out, are we about to embark on a new era? And this is just a sort of an indication of the trial, the EMBARK trial that was released at the end of 2023 in the New England Journal of Medicine, a 3-armed trial here that took patients with biochemical recurrence after either surgery, radiation, or surgery plus salvage radiotherapy, and a PSA doubling time less than 9 months, so a high-risk cohort, 3-arm randomization, enzalutamide and Lupron, enzalutamide alone, Lupron alone. Primary endpoint, metastasis-free survival, follow-up just over 5 years. And what they showed was that both of the enzalutamide-containing arms significantly improved metastasis-free survival compared to Lupron alone. To their credit, they looked at a variety of different secondary endpoints in the study, and very consistently, the enzalutamide arms were superior, including the fact that there was no substantial deterioration of quality of life in the enzalutamide-treated patients. So at the end of 2023, the US FDA approved enzalutamide for the management of hormone-sensitive non-metastatic biochemical recurrence. Nevertheless, before everybody goes off and writes a bunch of enzalutamide prescriptions, I would submit that there's some important considerations about this trial to dissect and to scrutinize. The median PSA at the entry to the trial was 5. Remember the graph I showed you before from the trial, the Condor trial. What is the likelihood of a positive PSMA PET scan in patients with a PSA of 5? It's over 95%. Patients in this trial were actually staged with conventional imaging. So the question remains, was this a truly non-metastatic population? We don't know the benefit at this point or the impact of using enzalutamide so early in a patient's disease course on subsequent therapies. And of course, at a health system level, we also have to consider cost of care. And of course, there's in this very nice editorial from JCO, it's critically important to remember that when we are treating biochemical recurrence, we are treating largely asymptomatic men, many of whom will live for years without disease-related consequences. We have to be mindful of not making the treatment worse than the diagnosis. So what do I want to leave you with in conclusion? Recognize the AUA definition of biochemical recurrence, but of course consider it in the context of the patient's disease risk, and we covered the features of what we would call high-risk biochemical recurrence. Remember that the natural history of biochemical recurrence is both heterogeneous and may be quite prolonged, so consider competing risks of mortality when making treatment decisions. Evaluate biochemical recurrence with a PSMA PET, especially if you're going to do salvage radiotherapy, but don't withhold the salvage radiotherapy if the PSMA PET is negative. When we talk about salvage radiotherapy, earlier is better, for sure less than 0.5, maybe even less than 0.2. Offer with ADT for patients with high-risk features. In terms of systemic therapy for biochemical recurrence, don't routinely utilize ADT. Yes, enzalutamide is now approved, but remember its toxicity, remember its cost, and again, recognize that long-term natural history of patients with biochemical recurrence. So again, I want to thank you for the opportunity to speak with you here this morning.